All righty. Good evening, everyone. Thank you so much for spending your time with us as we dive into this important discussion around prostate cancer survivorship. September is Prostate Cancer Awareness Month, and we want to take advantage of the opportunity to discuss prostate cancer therapy and some of the most common side effects that can occur after a man goes through particular treatments. So thank you for spending the next 45 minutes with us to join us in this educational webinar and for prioritizing your own health. As a few reminders before we get started, this presentation is completely anonymous. You aren't on camera and no one can see your name. We do this because we hope to have an interactive discussion. We want you to ask questions even if you think they're too embarrassing or if you don't know the right words to say. So to maintain your privacy, you can write your questions in the anonymous chat box at the lower portion of the screen. We will save time at the end of the presentation to answer as many questions as we can. We have over 25 people in attendance so far. So remember, if you have a question, somebody else probably has the same question. So don't be shy to ask. Our speaker tonight is Dr. Charles Kaplan, who is a fellowship-trained urologist and a men's health expert at Georgia Urology. Dr. Kaplan focuses his practice around helping men who are dealing with men's health issues, like many of the men joining tonight's webinar. He's a wealth of relevant information to share this evening. Dr. Kaplan, thank you for rushing home and taking time to join us this evening. If you're ready, I'll turn it over to you.
All right, great. Thank you. Thanks for that introduction. I'd like to thank everyone for attending tonight. I know the weather's terrible out there and it's only going to get worse, but I do appreciate it. Just a little bit about my background. I went to Emory Medical School, and then I went on to do my internship training at Cornell, and then my urology training at Georgetown. And I have 3 offices: Smyrna, Douglasville, and in Woodstock. So it is Prostate Cancer Awareness Month. So we were going to talk tonight not so much about the treatment for prostate cancer, but more what the potential complications and how we can treat those and deal with those complications after you've been treated. So we'll move ahead. Just some little background. Prostate cancer is one of the most common, it says non-skin cancers in America, affecting 1 in 9 men. It's actually the second most common cause of cancer-related death in men in the United States. There's approximately 200,000 to 300,000 new cases a year, and about 30,000 men die each year from prostate cancer. Some of the side effects of the treatment, and the 2 most common, are leakage of urine and erectile dysfunction. And those are really the things we're going to be talking about tonight, and how we can fix those problems if they happen to occur after your treatment. So what are the common treatments for prostate cancer? And these are for what we would call early stage prostate cancer, when it's curable. And there's really now 3 options that patients have when they're diagnosed with early stage or a low grade prostate cancer. One, if we look at the top here of this Venn diagram, would be radiation therapy. And radiation therapy there's lots of different ways you can give radiation therapy now. There's still seed implants, there's external beam radiation, there's proton therapy, but they all go under the category of radiation therapy. The other option is surgery, which has been around. That's the earliest treatment we've had for prostate cancer. We've been doing radical prostatectomies for probably 60 years now. And then active surveillance is one of the newer options that we now do. We've been doing this probably for the last 10 or 12 years, when we realize a lot of patients who have low-grade prostate cancer don't actually need to be treated right away. We could actually watch the cancer and monitor it closely, and sometimes it never even has to be treated. And like I said, that's more common now in the past 10 to 12 years. So one of the downsides to prostate cancer treatment is obviously the side effects. And you go through this whole thing, you get your treatment done, you're cured of your cancer, and now you have to possibly deal with some of these horrible side effects. And the 2 most common are incontinence, and most of the time it's stress urinary incontinence. But there's also overactive bladder or urge incontinence, and that occurs in patients who've had radiation therapy. But tonight we're going to focus more on the stress urinary incontinence side effect, and that's typically from surgery. So like I said before, about 200,000 men each year are diagnosed with prostate cancer, and around 70,000 of them will undergo radical prostatectomy. Now, radical prostatectomy has evolved over the last 20 years, and it's gone from an open procedure now to a robotic or a robotic-assisted laparoscopic procedure. And the good thing about that is by doing it robotically, we've gotten better with dealing and preventing some of these complications. And that's because it's done with magnification and high definition imaging. And you're able to see these little nerves right here, which normally with your naked eye, they're very difficult to see. And so during the surgery, the nerves are carefully dissected away, and we do what's called nerve sparing, and the prostate is removed. And then the urethra on one end is sewed back to the bladder. So the incontinence rate used to probably be over 20% when we did it open, but now with the better robotic surgeons, like the ones in my group who specifically just do that type of surgery, their incontinence rate or their complication rate is really, from my experience, is probably around 10%, which is very good. And when we say that 10%, so everyone will leak a little bit of urine after they have their prostate removed after surgery, and that can typically last from 4 to 8 weeks. And then after that, it typically goes away, and at the most, you might leak a drop or two with a big cough or sneeze. But we're focusing on the 10% where it persists beyond that period. And those are the ones that really makes their life miserable. So and that's exactly what this slide is saying. About 1 in 10 still have persistent stress urinary incontinence. And nobody wants to have to wear diapers after they've gone through this major surgery. And, they've been cured from cancer. They're happy about that, but now they're miserable with their quality of life. So as I just said, it makes you miserable. You're depressed. You don't want to do things anymore because of the leakage, and it really does affect everything. And this slide is just another what I just talked about, how everyone does have some leakage. It's normal, and it's typical. You'll go through. A lot of patients will do physical therapy or Kegel exercises for the first couple months, and that almost always regains their continence, like I said. So this is about only 10% of the patients it's affecting. So why are you leaking? Why are you leaking after your prostate's removed? Well, first of all, the prostate gland, if you didn't know, is a male sex gland, and its function is it has a function, and it produces the fluid that pretty much bathes the sperm when you ejaculate, and that's what it does. So the problem is where it's sitting. It's wrapped around the urethra, and because of that, if you get cancer in it, then the entire thing has to be removed, and it can affect your continence. So that's the reason it can affect urinary incontinence. So, because as you can see, urine normally would pass right through the prostate gland. And there's two sphincters when we're dealing with continence. One is the external sphincter. That's the sphincter that you can make yourself stop urinating if on demand. And there's an intrinsic sphincter, which is part of the prostate gland, and that's what's getting disrupted when we remove the prostate. So how can we fix this problem? Well, the simplest way is you can just deal with it. You can wear pads. There's clamps you can put on the penis. They make special underwear now that will catch the urine. But again, these are just, they're just temporizing agents. They're not curing the problem. So what are more definitive ways of treating this problem? And there's really two things. One is a male sling, which is this down here. This is the sling. And the other is an artificial urinary sphincter. Now, they talk about injections and bulking agents. We do have injections and bulking agents, but to be honest, they don't work very well in men. We use them more in women. And the reason they don't work well in men is there's just not a space to inject the filler. So it's just not there anymore once the prostate is gone. So we really focus on the things that will work, and that's the sling and the artificial urinary sphincter. So how does the sling work? Well, it's a hammock is what it is, and it's going right, it goes right underneath the urethra where the prostate, really in the vicinity of where the prostate used to be. And we're pulling up on these two ends here, And this is called a transobturator sling. It's the same sling that was developed in women 35 years ago, and then when they developed in men probably about 20 years ago. And the whole idea is it compresses the urethra, recreating a partial blockage to stop leakage. And it's used in patients who have mild to moderate incontinence. The artificial urinary sphincter, which has probably been around over 50 years now, it was actually developed before the sling, is a device. It's a mechanical device that goes 360 degrees around the urethra. It's called the cuff, and it's always compressing the urethra. And when you have the urge to urinate, you would squeeze this control pump, which sits down inside your scrotum, usually on one side or the other. And you give it a squeeze or two, it opens up the cuff and gives you about 2 minutes to urinate. And if you're not finished, you just give it another squeeze. And because this is what's called a pressure regulating blueness under pressure, it will force the fluid, which is saline, back into the cuff automatically, and it recloses. So all you have to do is push it to open it, and it recloses automatically. So this is now used in patients who have really severe urinary incontinence, or in patients who've had radiation therapy after their prostates have been removed. And the reason we do it in patients who've been radiated is because radiation affects the compliance and the flexibility of the urethra. Once it's been radiated, the urethra gets very firm and hard, and a sling will not be able to compress it well enough to stop the leakage. But a cuff goes all the way around and will do a much better job at closing off the urethra after radiation therapy. So this is an animation of how an artificial urinary sphincter works. Let's go ahead and we'll get it started. So this is demonstrating how you would squeeze the control pump to open up the cuff to be able to urinate. So again, it's going to be underneath the skin. You just give it a couple squeezes. It opens up the cuff and usually gives you about 2 minutes to urinate. And I can tell my patients, if you're not done, just do it again. And it works very well. The success rate of artificial sphincters is greater than 95%. All right, so how is the procedure done? An artificial sphincter is typically done as an outpatient procedure. It's done through 2 incisions. One incision is going to be in your perineum, which is below the scrotum and above the anus. And the second incision is going to be in the lower abdomen, typically similar to where you would have a hernia surgery on the left or the right side. And after the procedure, we actually do leave the cuff or the device turned off while it's healing for about 4 to 6 weeks. And then after that, you'll come into the office and we will activate the device and show you how to use it and make sure you know what's going on with it. And that's pretty much it. And then typically after that, you're done. You don't have to wear pads anymore. So it's a great procedure. Like I said, it's been around for a long time, 95% satisfaction rate. And most patients would recommend it to anyone really for it. And all the patients I've ever had placed it in, they've been extremely satisfied with it. Talks about insurance coverage. I don't think I know of any insurance that's not covered an artificial urinary sphincter because it's a complication from prostate cancer surgery. One of the things that what are the side effects or potential complications of the surgery is device failure. And we put that in here because it is mechanical. There is a valve inside that pressure regulating balloon, and if something rubber to break or go wrong with it, that does require another surgery to repair or replace it. The most common thing, though, that does happen with artificial sphincters is it's called, and it's not on here, it's called cuff atrophy. And since that cuff is squeezing the urethra 24 hours a day, the tissue will start to shrink up. And when that happens, it's no longer tight enough and you'll start leaking. On average, that takes about 6 or 7 years. And when it does happen at that time, then what we typically do is we have to replace the device, replace everything. The other thing you have to be aware of when you have an artificial urinary sphincter is you're required really to wear a medical alert bracelet. And that's because you cannot have a catheter placed back into your bladder without the device being turned off. If someone tries to put a catheter back in you while the device is activated, it's going to cause an erosion of the urethra where the cuff is. And once that happens, you're going to eventually get an infection, and basically the thing has to be taken out, and then we have to wait a period of time before we can put another one back in. So it's very important that patients always wear their medical alert bracelets. Now with a sling, it's not a mechanical device, so nothing's going to break with it. But the thing about a sling is it takes approximately 6 weeks for your body tissue to grow through the material. So it's very important that you limit your activity. You can't do any heavy lifting, nothing more than 15 pounds for 6 weeks after surgery. And the reason for that is if you do too much too soon, the device could slide down the sling and you'll start leaking again, and then it's over. But other than that, it's really not very painful. Most patients only have pain for a day or two. And that's really about it. So the key to the sling is just limiting activity during that 6-week healing period. So just to review, those are the two ways we do fix incontinence, and we can do it either if you have mild, moderate, or severe. There is a solution for this. All right, so the next complication from prostate cancer surgery is erectile dysfunction. And again, that can occur in patients who have had their prostates removed, and also occurs in patients who've had radiation therapy. So again, this is the same exact slide we saw before. Again, the nerves go right around the prostate toward the penis, and if they get damaged or even touched during surgery, it does affect your erections. Now, normally after surgery, we give it at least 6 months to see if the erections will return, and that's because nerves don't like to be touched. They almost get paralyzed for a while, so we'll wait a period of time before we say it's not going to come back. But we do know, and studies have shown, that if you have erectile dysfunction prior to your prostate cancer surgery and you're having to use oral agents like Viagra or Cialis, then the likelihood is much higher that you're going to have worsening erectile dysfunction after prostate cancer surgery. So it affects erectile dysfunction overall affects 25 to 75% of men, but that's for all options, so all comers. And most erectile dysfunction, believe it or not, in this country is not from prostate cancer surgery. It's from vascular problems such as diabetes or high blood pressure. So on this slide, it says it takes 2 years, but most patients aren't going to wait. They want to start treating their erectile dysfunction prior to 2 years. So typically how it works is we will, about 4 to 6 weeks after surgery, we allow patients to try to have sexual activity. We'll put them on oral agents if they can take them. And we'll give, like I said, we'll give it a period of time. And if that doesn't work, then we'll move on to more invasive treatments. And the next options would be vacuum erection devices, which is just a way of drawing blood down into the penis and then putting a tight rubber band at the base. And that's what this slide is showing. Injection therapy is typically what I would recommend if the pills aren't working, because that is actually placing the medication directly into the corporal body where the blood needs to be going, and it will work if we get you on the right dose. The downside is you have to give yourself a shot. And then there's also something called urethral suppositories, which they've actually been around quite a while, but their success rate is not great, so we don't use them very often. And then there's the surgical treatment, which is penile implants to restore the erections. So we want to talk a little bit about the surgical option. So a penile implant, again, is another mechanical device. It's called a 3-piece because there's 3 components. There's the cylinders. There's 2 cylinders, one on each side, and they take the place of where blood would normally be filling up the chambers. There's a reservoir that sits next to your bladder, which is going to be filled up with saline. And then there's the pump, again, which sits down in the scrotum, and that's how you would inflate the device. So again, all this is internal, nothing is external, and it's all self-contained. And now this video is another animation showing how a penile implant works. So let me get it started. So similar to the sphincter, again, it's down in the scrotum, the pump. Now this pump is much bigger than the artificial sphincter pump. This one's probably about 3 times the size. And the reason for that, and you can see they're pumping it up, and all it's doing is moving the fluid from the reservoir down into the cylinders. It's a closed system. And there's another button on top. When you're done, you squeeze it to deflate the device. So the reason the pump is so much bigger for the penile implant is because there's so much more fluid that it needs to be transferred to the cylinders. The amount of fluid for a cuff is minimal compared to the amount that needs to be, the volume that needs to be used to inflate the cylinder. So the pump has to be bigger. Otherwise, it would take forever to pump the device up. All right, we'll move on. So this incision also is considered an outpatient incision. It's done through one incision. And the incision, there's two ways to do them, and I do them both ways. One is at the base of the penis. We call that infrapubic. And there's also one you can go penis scrotal, which is through the scrotum. In my opinion, the infrapubic has less scrotal swelling, so that's typically how I do it. But I can also do it the other way if you had previous surgery down there, or you have another like hydrocele swelling around the testicle that needs to be fixed at the same time. We'll go through the scrotum and take care of all the problems at once. So it is fairly uncomfortable for the first couple of weeks after surgery. You have to ice it. And then after about 3 or 4 weeks, once the swelling's gone down, you can start practicing with the device, learning how to use it. And after about 6 weeks, you can have sexual activity. Insurance, and from my experience, it used to cover 100%, but now it's most likely going to cover around 80 to 90% of the times it gets covered. It is covered by Medicare, so we do know that. So what are the risks of a penile implant? Again, it's also mechanical. So again, if something were to break or go wrong, that requires another surgery to repair or replace it. One of the other risks, and it cannot happen with the sphincter too, but is infection. So if infection occurs around a penile implant, we first try to cure it or get rid of the infection with antibiotics. If that doesn't work, though, we have to take the device out and then wait a period of time before we put another one back in. So the success rate is very good with penile implants. The satisfaction rate is also probably greater than 95%. I don't think any patients, they work. And that's the thing. It does restore your erections, and the erection will last as long as you want it to. And then when you're done, you push the other button, it goes down, and that's it. So this is just more information where you can go to learn about the treatment options for erectile dysfunction as well as the incontinence. And these are the two websites. If you're interested in getting an appointment with me to talk over any of these treatment options, this is the QR code. You can just scan it, and it'll take you to our scheduling site. One thing I didn't mention is, there are patients who actually have both devices. And basically what you have to do is you just keep the two pumps on opposite sides of the scrotum. I don't like to do the surgeries together, though. I think that's too much surgery at one time. So we typically do the incontinence surgery first, because that's the most bothersome part and the most annoying. We want to get that fixed. And then at a later date, we'll go back and put a penile implant in. So I think that's pretty much it. I think we can probably open it up now for questions.
Yeah, guys, just as a reminder, feel free to type some questions in the anonymous chat box if you have any that pop up. Other than that, Dr. Kaplan, I'll kick it off with a few questions we got in the box throughout your presentation.
Okay.
How long do I have to wait after prostate cancer treatment before seeking treatment for erectile dysfunction and/or leakage?
So that's a good question. Typically I would say 6 months. Usually 6 months is the number for both erectile dysfunction. If you're not seeing any improvement, that would be the earliest we would consider doing something surgical. But if you want to try the other treatments for erectile dysfunction, you can start using those within 4 weeks after surgery. And that would be the, pills, oral agents, injections, vacuum erection device. You can try that almost right away. But the surgery, we're going to wait about 6 months. Now for incontinence, same kind of thing. Most patients have to go through a period of time of healing. They'll do physical therapy. And I have 6 months is typically the time that we would do a surgical treatment for incontinence. However, with that said, I've done it as early as 3 months. And that's been in patients who we know, let's say they were going to have radiation after their surgery. And in that set of patients, we like to get the devices put in before you get radiated. So we'll do that as soon as 3 months after surgery. But if you're not going to have any form of radiation, then we'll wait 6 months.
How do I know if I'm moderate or if I'm severe for bladder leakage?
So that's a good question. So typically, everyone, we sort of do it through the number of pads you use, but that's not the best way to measure it, because some people will change their pads when they have 2 drops in them, and some people will change their pad when it weighs 5 pounds. So, but it's really done by weight. So, but on average, for the average person, if you're 4 pads or less a day, we consider that mild to moderate incontinence. Around 5 is moderate. And then when you start getting about 5 pads a day that are fairly heavy, that's considered severe urinary incontinence. And what I typically do is I just sort of get an idea. I feel the weight of the pad. I ask patients when they put the pad on, I weigh it, and just knowing how much is in there after a certain number of hours gives me an idea of really what you're going to need. Fortunately, most patients only need a sling, and a sling obviously is a little bit simpler surgery. And if it works well, you're done. You don't have to do anything else, and it doesn't require squeezing a pump or any potential for anything to break when you have a sling. And another thing about a sling is it doesn't prevent you from having an artificial urinary sphincter down the road. So if we put a sling in, it doesn't work well enough. And or patients, what I see a lot of times is it does work, and then unfortunately they'll have to get radiation a few years later, and then it stops working, and then we'll go ahead and put a sphincter in still. Now, we don't remove the sling. That's always stays in place. Once your body tissue goes through it, it's pretty much permanent. It's not going to move. And so what we do is the cuff will just go beyond where the sling is sitting. We put that in. So that's how that works.
Okay. How much does a penile implant typically cost? And should you get an implant if you're getting sporadic erections, but they aren't lasting very long?
So the cost, that really depends on what your insurance coverage is and what your deductible is. So um, I can't really, that's all I can say about that. If you're getting, the real problem is if you're not getting erections that are hard enough to penetrate or lasting long enough, and you've tried everything else, then it's time for a penile implant.
Okay. Once 6 weeks post-surgery, can I ride a bike without worsening the urine linkage?
So after the 6-week mark, specifically with a sling, yeah, I mean, the sling, so all these things are made to stop leakage with stress incontinence. Now, obviously, if you generate enough force from whatever you're doing, it could potentially leak through a sling or leak through the sphincter. I mean, that's just the reality of it. But typically, you should be able to ride a bike after 6 weeks. I mean, if you go lift 100 pounds after you had a sling or a sphincter, yeah, it may leak through. Or if you have an artificial sphincter and your bladder starts contracting on its own, just closing down, it's not meant to close that kind of pressure back. That's more than what we would call stress incontinence. The pressure gets up to like above 100 psi, and then it's going to leak through. But for doing routine stuff, they work.
How many years will the implant work?
Implants work on average of about 10 years, and then they have to be replaced if they're not working.
Is it safe to take erectile dysfunction medications every day?
If it's a low dose, I mean, we do with the Cialis is indicated for daily use, but it's just at a lower dose. Viagra's not really indicated for that, but Cialis is the only one you can do that. But in my opinion, the lower dose doesn't work as well as the higher doses. So I typically tell the patients if they're using it for erectile dysfunction, they're better off just taking it the higher dose as needed.
Prior to the sling, will I need a cystoscopy? And if so, does this hurt and how long does it take?
Yeah, so that's a good question. So the workup for incontinence surgery that I do, the only thing that I really require is a cystoscopy. We have to do a cystoscopy before you have a sling or a sphincter. And that's because I need to check the anatomy. I need to make sure your external sphincter is working. And more importantly, I need to make sure there's no scar tissue where they did the surgery. Because if I find some scar tissue or something called a stricture or bladder neck contracture, that needs to be dealt with before the incontinence surgery. And the cystoscopes, actually, they don't really hurt because it hurts going through the prostate. So if you've had your prostate removed, it doesn't really hurt at all, but we do numb it up with some lidocaine jelly.
5 weeks post-surgery, and I've noticed leakage only while standing or walking. Is this a good sign?
As long as it's improving, yeah, then that's still within the, we would still consider that, normal at that point. So we get more concerned after 8 to 12 weeks if there's still leakage.
How much pain and soreness do patients get after an AUS surgery?
Actually, it's not very painful at all. I mean, there's just incisional pain. And, the recovery from doing heavy lifting, when I say heavy lifting, 15 pounds is probably just a couple weeks. And you can go back to, doing normal activity after that. Unlike the sling where you can't do any heavy lifting for 6 weeks, but with the sphincter, it's just a couple weeks. There's not much pain. They need a couple pain pills, either surgery, and that's it. It's not like it's just where the incisions are, and we're not really going through any muscles or anything, so there's not much pain.
Are there any lifestyle activities like riding a bike or a motorcycle that could make my incontinence worse?
Well, riding a bike, obviously, you potentially could because you're sitting on that area where the prostate used to be. But, and it would be more related to the length of time you're on the bike too. So if that is making it worse, obviously you need to modify the activities if you've noticed that's what's doing it. So like I said before, it's all about the pressure, the abdominal pressure. You get your, whatever your, what we call leak point pressure is, and everyone's going to be different. Once you go beyond that, you're going to leak.
Will an implant affect how a climax feels?
An implant will not affect how a climax feels. No. Now, obviously, if you had your prostate removed, the climax is a little bit different, but no, it does not affect that at all.
And how long is the hospital stay for a sling?
A sling is an outpatient procedure. The surgery takes about an hour. You do go home with a catheter in overnight, and I actually have my patients take the catheter out themselves the next morning. Artificial urinary sphincter, some patients will spend the night. If they do, it has a small catheter in, and it comes out the next morning. Or if you go home, you're going to take it out yourself the next morning. The reason we leave the catheter in is it's just not worth the risk of you having problems at home that night and having to go to the emergency room if you weren't able to urinate. So we just always leave them in, and you take it out the next morning.
Okay. Are there certain prostate cancer treatments that are least likely to cause erectile dysfunction or urinary incontinence?
Yeah. So, like I said, there's either some form of radiation, or there's surgery. So surgery, unfortunately, does have a higher risk of incontinence. It's just the way it is, the nature of it, more so than radiation. So radiation doesn't cause stress urinary incontinence because we're not removing the prostate gland, but it can cause overactive bladder or urge incontinence. So, but that's treated differently. That type of incontinence is treated medically, with medication if you have urge incontinence. Erectile dysfunction can, occurs with both procedures. In my experience, it may be slightly worse with surgery than with radiation.
Are there any reasons why a patient would not be a good candidate for any of these surgeries?
Well, they have to obviously be medically cleared. They have to have undergo anesthesia. And that would really be the only reason. I've done it in all, lots of different patient types and body habitus and everything, and pretty much can do it in almost any patient as long as they're cleared for, as long as their heart and lungs are okay and they can have anesthesia, they should be able to have the procedure.
Okay. I'm 74 years old. Is that too old to get an implant?
No, that's the average age I put them in is probably around 68 or 69. And I put them in patients up into their upper 80s. So no, as long as you have, and there's other types that we didn't go through all the different implant types, but as long as your dexterity is fine and you can squeeze the pump, and you can have an what we call 3-piece, but they also make what we call malleables, and they're just bendable rods if you have problems pumping it up. So the answer is no, you can do it almost at any age. There's something available.
know you mentioned one of the side effects of a sling is urine retention. Can you explain this a little bit more?
So urinary retention is rare after a sling, but obviously we are tightening things up. And if you weren't able to urinate when the catheter came out, that's the other reason I do it in the morning. If you haven't urinated with usually 5 hours later, you have to come back to the office and we'll put a catheter back in. And then the catheter stays in for a few days and we try again. If for some reason you're still not urinating, let's say 10 days out from surgery, at that point, what I do, there's a way in the office we can actually loosen up the sling. And, I've probably had to do it a half a dozen times over the last 15 years. But it works. After that, the patients are able to urinate. But we do usually have to do that loosening procedure within 2 weeks of the surgery if we're going to loosen it up. And that's how I deal with my patients. I don't really make them self-cath or anything like that. It's just too complicated. The simplest thing is just to loosen the sling within the first 2 weeks now. So we can loosen slings, we just can't make them tighter. So if you're still leaking afterwards, I mean, we always make them as tight as we can. I make every single sling. Do it the same way on every guy. I make them as tight as I possibly can. And if it happens to not be tight enough, there's not much else we can do about that.
Alrighty, just a few more questions. I'm only a few weeks out from surgery and I'm leaking. When should I set up a visit to assess this with you?
So assuming you're doing your physical therapy or Kegel exercises, I would give it at least 2 months.
Do I still have the same feeling to urinate after the AUS surgery?
You do, because when your bladder will stretch back out and it makes you actually gives you more urgency to urinate. Especially if you've been having a lot of leakage for a long period of time. I mean, I see patients who've been leaking like for years. And if you're leaking like that and your bladder never refills, it shrinks up. So you get a really strong urge. And, but over time, the bladder will stretch back out and you'll be able to hold more urine. So yes, you're going to still get an urge.
Alrighty, just last question here. Is there a risk in waiting to treat erectile dysfunction? Does it make it harder to treat later?
That's a very good question. So what happens if, let's say you're just not getting good erections, you're not getting any erections at all after surgery or from whatever cause. The reason we have nocturnal erections or morning erections is because the blood that goes through the penis and those corporal bodies, it's oxygenating that tissue. And if you're not getting any erections at all, you're not getting good oxygenation in there. And then over time, and I say over time, over the course of years, you will get some fibrosis of that spongy tissue on the inside. And when that happens, one, it shortens the penis. So it will shorten it some. And it does make it a little more difficult to get a penile implant in. So can we put them in? Sure, we can. As the surgeon, it's clearly harder surgery if we do it, 5 years later versus 2 years later, after the problem. So yeah, so that's saying if you don't use it, you lose it. That's sort of true. It does affect the tissue inside the penis if you're not getting erections.
Alrighty. Well, thank you everyone for joining and being super engageful in the chat. And Dr. Kaplan, thank you so much for giving us this wonderful
Oh,
presentation.
you're welcome.
I will let you end it with any words that you'd like to say before we wrap it up.
I would like patients to know, and most patients don't know there's a solution other than pads. I mean, I feel so bad for patients that go through the cancer and they're happy they're cured, but now they're miserable with the incontinence, and that just doesn't have to be that way. And the patients who I do these procedures on, it really is life changing, and they're so thankful that they wish they had done it earlier. Let's put it that way. And I don't blame them. I mean, erectile dysfunction is important too, but it's not affecting their life, basically, every hour of the day. So these are problems that can be solved.
Thank you so much, Dr. Kaplan. We really
Thank you.
appreciate it. Thanks, everyone. Y'all have a great night.
Thank you.